Good morning, sir.
Good morning. Okay, we have few cases here. We can give 1 more minute to other people to join us. I know that
Good morning, sir.
Jamil has a case, a trauma case that I'm very interested to know more clinical details. Why don't we do that first, that case first? But let's give it 1 more minute. Dr. Jamil, are you going to be able to share your pictures?
Yes, sir.
Okay, then why don't you, I would say you can go ahead and share your pictures and give us some clinical information and we go from there, okay?
Okay, yes, sir. So shall I start with my presentation, sir?
I see Dr. Remy Nader as well joined us. Remy? Let's see here. Hi, Remy, are you there?
Yeah, I'm here. Can you
So I
guys
know
hear me?
that you have
Yes.
some scheduling thing and so on. If you like, we can talk about your case first so that you can go and do your other duties and so on.
Yeah, absolutely.
Okay, so here, I'm going to share my screen with your picture, Dr. Jamil. Let Dr. Nader present his case first, and then we will talk about your case. So here is the picture you sent me, Remy. Okay, why don't you give us some clinical information?
Okay, so this is a 55-year-old lady who had some kind of an accident, like a fall or a car wreck back in September of last year, so about 7 months ago. Developed severe back pain. Initially, it was up to a 10 out of 10. Now it's like a 7 out of 10. She also has right sciatica, sort of right-sided leg radiculopathy. That's more intermittent, but almost as severe as the back pain. The back pain is mostly axial mechanical. She's essentially tried and failed all the conservative treatment. She's had more than 4 months of therapy, 2 epidural steroid injections, multiple medications, muscle relaxers, NSAIDs, and so forth. She's about a normal BMI, maybe a little bit overweight, like 27. Otherwise, in reasonable health for somebody in her mid-50s, basically.
Okay. Now, you said the sciatica. What are the dermatomes that are mostly
So
symptomatic?
multiple dermatomes, primarily tibialis anterior, but she also has some iliopsoas and quadriceps weakness. She has sensory loss in right L4, L5, and S1 distribution. She's got a right-sided limp when ambulating. I did not check a straight leg raise. It was kind of in a hospital setting. It was a little bit harder.
Yeah.
Now, I've studied her a little further. I did a discogram. I ordered a discogram, and I also ordered an EMG. So the discogram was positive for discogenic pain, severe pain, at least a 7 out of 10 at L3-4, L4-5.
Okay.
I guess the examiner was unable to penetrate the L5S1 disc with his needle.
Yeah.
May not be a very experienced examiner. I'm not sure. It was sent out to a pain clinic. The EMG was positive for right S1 radiculitis, basically.
Okay. Let's start with few questions. You said the patient has maximized non-surgical therapy, conservative therapy. Any surgeries, any like decompression or
No spinal surgery.
Okay.
No.
And you
If
said
you show, I'm sorry to interrupt you. If you can show the axial lower down at the L4, 5, L5, because you see that there is some stenosis as well.
yeah,
It's not
there is
severe,
definitely
but
there is. Definitely there is. Yeah, and you see a
yeah.
foraminal, extraforaminal circumferential disc herniation in 5S1. But why am I talking about that? Does anybody want to go and explain what we see in these pictures before we talk about options? You see definitely some hyperintensity in the facet, definitely some facet disease, disc herniation, which is not super severe, but and then degenerative disc disease in all levels, especially in 4-5, and symptoms are corresponding to that as well.
Yes, that's correct.
Yeah. So, and then the question will become here, if conservative therapy has been maximized, and do you consider when you say conservative therapy maximized, are you as well talking about that the procedural thing like ESI, MBBs, and things of that nature? Are you including them in your non-surgical treatment?
Yes, absolutely. She's had 2 ESIs, and there were multi-level ESIs. Like I think they did L4, L5, S1.
Got it.
Transforaminal ESIs,
And
in addition
patient,
to the therapy and the meds and the anti-inflammatory. So yes, certainly
this
that
has
is
been going
included.
on as well for a while, I'm assuming, like more than 6 months. Is that correct?
Yes, we're
Okay.
going on 7, almost 8 months now. Yes, that's
Got it.
correct.
Okay, so let's put it to the floor. What are the options? This patient has severe pain. Conservative therapy is done. Images are indicative. They correspond to the symptoms, but by themselves are not really super impressive. So, what are the options?
Is it neuraxial or radicular in nature? Like, is it more back pain or is it more
Both.
radicular? I missed the first part.
Yeah,
Both?
both. Yeah.
So it's both, but the axial component is a little bit more severe than the radicular. It's constant versus the radicular that's intermittent, I would say. But it is both, yes.
So, I mean, when I talk to patients from a pain perspective, I try to educate them. I think I can usually count 5 or 6 potential pain generators. There's the disc itself. Then the disc, when its inner contents lead onto the surface of the end plates, you can see here that white. I bet the radiologist called out modic changes. That can be painful.
Mm-hmm.
There are the facet joints those can cause pain. There's the nerve roots themselves. And then I always throw in the sacroiliac joint, which is another potential pain generator.
Absolutely, yeah.
But so I learned from Hamid that at least with the sacroiliac joint, if you isolate that, and that's really the main pain generator, despite everything else that's going on in the back, that can, if that really is a pain generator, then you have a really elegant solution that will make your patient quite happy. But it's hard to know what other. So she's had epidural steroid injections. Any of the other structures, have they been targeted?
No other types of injections, but I did, palpate her SI area. She didn't really exhibit any significant tenderness, like the Fortin's test, whatever, the
Faber.
I wasn't impressed with that. So I think it's more originating from the lumbar spine rather than the SI joint, at least from a clinical standpoint, examining the patient.
Yeah.
If she was coming to me from the pain clinic, then my first algorithm would be epidural steroid injection, which already has been done. I just go for low hanging fruit, unless it's obvious they need, a spine surgery, sooner than later because they've got motor changes. But then I would at least try facet joint, meaning medial branch block, which is diagnostic without steroid. If they get really profound relief, you can go ahead and burn their medial branch nerves. Maybe that gives them some time. If they have incomplete pain relief from the medial branch block radiofrequency ablation route, I have a low threshold for just injecting some, even just local anesthetic in the sacroiliac joint and local anesthetic and steroid in the joint, because I have many patients who I treat the facet joints, and she does have definite facet joint hypertrophy. I treat the facet joints, they get great relief from the temporary blocks, but incomplete relief from the ablation. Then I inject in the sacroiliac joint with some steroid and local anesthetic. Some people do well for 6-9 months with that combination. And then if I've ruled that out, then maybe in a patient in our in the US, you can only do this if you have Medicare, but you can also go in and burn the basivertebral nerve.
Yes, yes, that is a
That
new thing that some people say, and some people even say the real reason why kyphoplasty works is that because of the exothermic effect of the bone cement that you
Mhm.
put in the vertebral body. It has been a new development there and so on. And
that
Remy, are you familiar with that basovertebral ablation, nerve ablation?
I've seen it here and there, and some of my colleague pain specialists that have done it. I am not personally familiar with it, I would
Yeah,
say.
yeah.
So,
I haven't done it myself either, but it's
mhm,
practically a sort of kind of jamshidi that bends, almost look like a
Mhm.
jamshidi that bends, and
Mhm.
then you bring it to the mid-vertebral place that you're interested, and then you apply the radio frequency to heat up the tip of the probe. I have been asking in our society about the results about that. The results are scarce. You hear anecdotal of this and there that it works and so on, but I haven't had really access to good quality information if it really works or not. But there's a lot of buzz about it out there. If
my my
somebody
my
else has
take on it,
information.
it's not where I go first. I mean, it's from the pain physicians and our nurse practitioners. If they see modic changes, that's like a
Mhm.
trigger that you can do this. The challenge is that I don't have a specific diagnostic test to do. It wouldn't make a lot of sense to go in, get all the way in the vertebral body, put local anesthetic, and then just pull out and come back a
Yeah,
different day.
that makes no sense. Yeah.
So the classic patient that seems to do well with this is a patient who has more front, like anterior column pain. So they have pain when leaning forward as opposed to pain when leaning backwards, which is more facetogenic in a lot of cases. Um, and then there's this other symptom that if I see patients with this, they tend to do quite well with it. It's called, I call it restless back syndrome, meaning they just really can't find a comfortable position. If it's more neurogenic claudication and spinal stenosis type symptoms, they usually don't have pain when they're sitting and resting. But again, if you look at this spine, there's all of it. There's radiographic evidence of
Yeah,
everything that
yeah.
we've just talked about. It
And
seems to be the trouble is targeting which structure might be causing the most pain and then
Mhm.
offering the least invasive solution and then going from there. But
and
sometimes
there
you don't know what is really the pain generator until you go and anesthetize the structure. And
yeah.
and then even then, then even
The
then, especially in the spine where there's a lot going on, it could be multiple things causing pain.
The reason I like this case is that obviously everybody likes to show their grade 3 spondylolisthesis and the deformity and so on, but the vast majority of the cases
Mhm.
we have to deal with in the spine are these shadowy, questionable cases like this, where you have done everything you can do, and literally you believe the patient, you think they're genuine, you know it is real, and then you have run through all those things, including all those, the standard and non-standard treatment, and then the question will become, can we help this patient?
Mhm.
Now, Dr. Jamil, um, at this point, with the information you have, let's go just put it to the vote, and I will be last. I come last. Dr. Jamil, what would you do for this patient based on the information you have? What would be the next thing you are going to do for this patient? And let's be clear, it is acceptable to say the next thing is that send the patient to a pain specialist. I don't deal with that. That's an acceptable answer, okay?
Yes,
But
sir.
what is what you would do for this patient?
So first of all, for the axial pain, I'd like to get his flexion extension X-rays, dynamic X-rays of lumbosacral spine, to see if there is any movement and
Let's say
sir,
there is none. Let's say
yes,
there is none.
yes, sir. And sir, and if the patient's main concern is his radicular pain, then I'd offer him a transforaminal injection.
No, we heard that the main symptom are axial pain. We heard
So,
that from Dr. Nader.
So for axial pain, sir, I think I would refer the patient to the pain specialist
Okay,
because
good. That's acceptable. You see, this is an open forum that we can say, okay, in a situation like that, my next step is, I just send the patient to a pain specialist. Okay. So, Dr. Raouf, what is the next thing you would do for this patient?
Because Dr. Nadir said that he has used the injections and patient's pain not improved. So next option is if the patient is pain is not improving on the injections, then it's most probably the radiofrequency ablation will not work. So we will at that stage patient has a pain for more than 6 months, or the physical and medical and the injections has been failed. So we will forward for the surgery because patient main complaint has both the axial pain and the radiculopathy. So fusion and decompression. I will go
Well,
from
I
there.
see that you have read that document that we put together very thoroughly. So, yes, that is an option. Now, let me be very clear, not doing surgery for this patient as a surgeon deciding this is something that I don't want to get involved. It's an answer you can say, but I'm not saying that people who don't do the surgery for this patient are wrong. But as Dr. Rauf was saying, doing surgery is as well an option. But Dr. Aya, tell me, in your hand, based on the information you have, what would be your next step?
So unfortunately, I think I missed the first couple parts, but whenever these patients come to me a lot because that's kind of what my practice is. I have interventional pain specialists. After they're done with all their injections, they send the patients. And a lot of patients will come in and say, I have tried all the injections and they don't work. I need something else. What I do is I start with a very in-depth history and physical, because a lot of times you need to elucidate which one actually helped, even if it was for a day, an hour, a minute. Which one of those injections helps you the most? Which injection, if I repeated that and gave it to you for the rest of your life, would you be actually pleased with?
Well,
And
let's
most
say in this
patients are
patient,
able
Dr.
to say
Aya,
something.
Dr. Aya, let's say in this patient, the exam was thorough, patient has corresponding symptoms to L4 and L5, and patient has maximized completely non-surgical treatment, and you do believe patient has a genuine pain, and clinical symptoms do correspond to these levels, what we see in the pictures. So let's consider all of that, and now you are at the fork in your decision-making process.
So that's where the diagnostic injections I use as a tool. So
Yeah.
out of the epidural, out of the SI joint injection, out of the transforaminal, out of the facet block, which one did you have the most?
So, Remy, do you have
benefits
any
with?
information about what the result of those injections were? Obviously, they didn't work. Otherwise, you wouldn't discuss it with us. Patient
But
would
they could be diagnostic,
Yeah.
not therapeutic, but at least
Yeah.
diagnostic.
Remy, do you have any information
So-
regarding that?
So there were two injections done. Both injections were epidural steroid injections. They obviously did not work. They were at L4, L5, and S1. So L4, L5, L5, S1 levels. Okay. It's not that they worked for a little while and then they weaned off. They just didn't work. Okay. If anything, she had additional soreness from the injection site in addition to her axial back pain.
Yeah.
Okay.
Was it do you know if it was transforaminal or interlaminar approach?
I believe it was transforaminal.
Okay.
Okay.
Yep.
Well,
So that was targeting a specific nerve root. That can be more diagnostic than interlaminar.
So, but then essentially what we've diagnosed is that he doesn't have lateral recess or severe radicular components. So for me, they would go back to a pain specialist to rule out facets and all of those other things.
So let me tell you what
if
I
there was
do in my practice here. Now,
if there's no temporary relief, though, then it's probably not radicular, no?
Yeah,
Because
exactly.
you put local anesthetic around a specific nerve root.
Right. So
But
to
we
me,
just heard that the most of the patient's symptoms are axial. Dr. Nader told us that. So I believe these are the points. I believe the patient. conservative therapy is done, all the diagnostic so far is indicate that this is axial discogenic pain, maybe some facetogenic pain. Certainly, medial branch blocks and radiofrequency ablation should be discussed with the patient. I think the most EMG NCV is not a big indicator for me in my practice, because most of the information I can get from EMG NCV I can get from a physical exam. Discogram, I use it in a situation like that exactly for the purpose to find out if there is a discogenic pain. Unfortunately, they couldn't get 5S1, but looking at that picture here, you see that there's quite a circumferential disc herniation in 5S1 and symptoms. When patients have L4, L5, and what I heard as well, possibly partial S1 symptom, this correspond to that. And I heard that the discogram was positive for what level, Remy? For L4, 3, 4, 4, 5? Is that what I heard?
Yes, that's correct. 3, 4, 4, 5. They did also enter 2, 3 as a control level, and 2, 3 was negative.
That's important. That is important. So I think one of the major thing in the 4 criteria. Now, discogram are controversial, have been controversial. Some people say, I believe in it, I don't believe in it, and so on and so forth. But if these following 4 criteria are given, I absolutely think they're very powerful. Number one, you don't just rely on morphology, but morphology is only one factor. That you have 1 hole or you have 10 holes. When you put contrast in and it goes to the lateral recess, and that's usually the weak spot, and patient has symptom in that there, this is in front of your face, but that's not the only factor. So morphology is one factor. That the appearance, morphology, and result correspond to the clinical symptoms, it's another thing. That patient has L4 symptom, and I see that morphology as well shows herniation and the extrusion of the contrast to the, if you have L4 symptoms, it can be a lateral recess of 3-4 or foraminal extraforaminal at 4-5, correct? That is how you correspond to that. So corresponding clinical symptom morphology, corresponding clinical symptoms, negative control level. That is, I cannot emphasize how important that is, that we get a negative control level, and it is not everything is painful, and it's not that sort of sorts out a lot of things. And I think the 4th factor for me is at what level is it symptomatic? That's one of the things I admire about your work, Scott, is that you give me if it was painful at 90 psi or it was painful at 15 psi, you know, or at least note the compliance of the disc. Literally, is the disc that you put in and you cannot even build up pressure, and it
then it's
right
leaking
away.
all over the place. It's still a problematic disc.
Yeah, but you have to put all that data in your decision-making process.
Yes.
Okay, you put the contrast in and it's not painful, but then you look at that, you put 10 cc, as soon as you put it in, it leaks out. So you cannot even build the pressure. So all this information have to flow in. And in this case, if again, with all those criteria, I would give this patient an option of the surgery. I have had very good results with patients like that, with getting rid of that discogenic pain. Now, facetogenic pain is a thing. It's really true. The facet in all our joints, the facet is extremely painful, as everybody who has dealt with the musculoskeletal, we know. But 9 out of 10 times, the facet problem is a consequence of a disc problem. Why? Because 80% of our weight carries over the disc. If the disc is incompetent and facet has to carry now 60%, 80% of the weight, they will wear off. Then you have it hugging facet. Then you have the facet effusion, fluid in the facet. Then you have this hugging facet. And then, but the solution is the same. You have to immobilize that segment. You have to do a fusion. And I have had fantastic results with this patient that have been declared pain seekers and so on and so forth. They had to fight 15 years and we do a 1 hour surgery, they go back to work, they go back, have our nurse, they're off narcotic, and so on and so forth. So I absolutely, Remy, would offer this patient, if those criteria are given, I would give this patient option of, I mean, you can do basilovertebral ablation, you can do MBBs and so on and so forth, but surgery fusion for this patient should be in the mix. Okay, I'm not saying not doing surgery is wrong, but I'm saying it has to be in the mix. And what kind of surgery? The surgery that's best in your hand. Whatever immobilized that segment. And I dare to say if that even artificial disc in the future, but I'm not a big believer in artificial discs now because the mechanic of it just doesn't work. And as well, if there's a facet problem, okay, you keep the motion there, and then the pain, then you give them a facetogenic pain and so on. So Remy, I would offer, if based on the information I got, I would discuss with this patient basovertebral nerve ablation, MBBs and radiofrequency ablation, but as well OLEF for this axial back pain. I have had very good results with that.
Can I make one comment that I think I like? So I see patients that come back to me who've had spine surgery, and they have modic changes on their at the end plates and still have pain, but I can't access because they have pedicle screws. I can't access to burn that basivertebral nerve, and I don't think this study has been done. But I just wonder if perhaps before putting in pedicle screws, you go in and ablate that basivertebral nerve. If the outcomes from spine surgery might be better, at least with regards to axial back pain.
Well, could be you're on something, Scott. But let me tell you something. You don't have to go through the pedicle to get to the vertebral body. You know that, right?
I know there's peripedicular, but if there's a screw in there, I mean, burning the nerve with a screw, I don't know. I don't know if I can maneuver it, but I'd be happy to try.
It is well, I'm just telling you, technically, you can still get to a vertebral body. You just go to the base of the pedicle, and the pedicle screw is occupying maybe 1/5 of the width of the vertebral body. Okay. And then you come very lateral. You go to the base of the pedicle, and then you bypass the thing. Technically, you can do that. Now, if it's really worth it or not is a different question. But technically, it's absolutely, as a matter of fact, it is not very rare that my pedicles are so small that I do the so-called extrapedicular. I just did one in Crookston. I put both my L2 screws, I put it extrapedicular. And patient did fantastic. Patient came from Kansas, and we did that, and patient's already on the way back to Kansas and so on. So it is technically it's possible. So
you go the base of the pedicle. I've done it once or twice.
Yeah. You know, when the pedicle is like 4 millimeter, and you want to put the smallest screw we have is 5.5.
Okay.
If you're lucky, you can get 5 screws. I wouldn't really ever put a 4 millimeter screws in lumbar spine or anywhere, as a matter of fact, except in the neck. But you go to the base of the pedicle instead of to the top of the pedicle.
Okay.
And then you just come more lateral and you put
more lateral.
Yeah.
Okay.
Dr. Gujar and Dr. Aya and Dr. Rauf, have you guys done that extrapedicular intentionally? Have you done intentionally extrapedicular screws?
No, sir.
No, sir.
Okay. Yeah, it is not that uncommon. And as well, if you do that, obviously, we try to be.
Fortunately, I have.
It can happen. Sometimes you just have to, once you do that, you just have to say, I was planning it from the beginning to do that. That's what you have to say. Okay. Remy, I think you got some answers here, and I would definitely offer this patient fusion.
One additional question before we go. So we're looking at a 3-level fusion here. Is there like a preferred approach, or is basically whatever the surgeon is comfortable with?
Whatever you're comfortable with, but let me tell you about soft transition. In the soft transition, we have 6 level and now as well 7 level. The level 1, so I do that. So this surgery, L3 to S1 fusion in my surgery center, my average time is about 1 hour and 15 minutes. And my patient usually go home 3 hours, 4 hours after the surgery. It is a whole protocol. You have to manage their pain during the stay in the surgery center and after it's a whole protocol to optimize them that they don't go back to ER because it's big surgery. You put 3 spacers, you put 8 screws, you put 2 rods, lots of holes in. You have to prepare the patient. We have a pain protocol. It's a 2-page, exactly how to manage this pain of this patient around the time of the surgery. In the soft transition, is definitely this is not the level 1. The level 1 soft transition is about L1 to L5, and you should do literally 50 of those before you go to level 2, which is L5S1. Then level 3, you endeavor into grade 2 spondylolisthesis. Level 4 is L5S1, grade 2 spondylolisthesis and scoliosis less than 15 degree. Grade 5 or level 5 soft transition is scoliosis more than 17 degree and vertebral rotation, but rotation less than 15 degree. And level 6 and 7 is the lower thoracic, the thoracolumbar and rotational deformity up to 35 and scoliosis up to 55 degree. And level 8 is the thoracic, the direct thoracic and so on and so forth. So, and the reason we have created that based on thousands of cases and based on literally over 10,000 clinical information data points is that they build on each other. It is like before you do flips, learn how to jump, something like that. Or before you land a 2-engine airplane, learn how to land a first 1-engine airplane. So they build on each other. So
random interjection, or you could just do a fellowship with Dr. Abbasi, and you'll graduate at a level 3 to 3-ish, but with the confidence of a level 9.
Yeah, like you have seen Dr. Gasco. You have seen Dr. Gasco, how masterfully he does this grade 3 L5S1 spondylolisthesis. I mean, I'm really impressed how he does that. And you remember Gasco, right, Remy? He has.
Oh yes, I remember him very well. We talk periodically actually,
Yeah,
and we actually wrote a book together, as a matter of fact. So
he has made a huge name of himself in El Paso, and people are coming
yes,
from far away to him. He does this grade 2, grade 3 L5S1s and under an hour and so on. So he has been quite successful to build that practice for himself. But what I'm getting at is I'm happy to scrub in with you if the environment is right. And as you know, we have that hospital in Houston now that hopefully within the next 3 months we are going to open. But you probably don't want to wait that long. But I'm happy to scrub in with you in the right environment and just be as of assistant as much as you see. But talking about the patient, that's the most important thing. I would, if I believe this patient with the symptoms, I would definitely give this patient option of the fusion, because the alternative is this patient is going to go from doctor to doctor, get a spinal cord stimulation device, get a pain pump, and then they will quit working after 6 months to a year, and then patient get pushed to a corner that they become defined as a drug seeker and so on. And then we will make the life of this patient to a living hell in the next 20 years. And then by then the changes are then enough to justify a regular. So this patient will lose 20 years life before we spine surgeons start thinking about actively helping this patient. We should go and help this patient now, Remy.
But thank you very much, Hamid. And I have to go at this point, but thanks everybody for all your input regarding this
thank
case.
you, Remy. Okay, so
can I make one comment about your, at least with the OLIF procedure? Why I recommend it for patients is just that because you preserve the posterior spine muscles, which I think feed. I mean, that's one of the major ways that the discs get nutrition. I mean, otherwise if there's a
Yeah.
scar tissue there, it seems like they just continue to degenerate at a
Yes,
faster rate.
75% of the vascularization of the bone is through the posterior musculature, 25% is through the iliopsoas from the front. So by posterior approaches, we are literally reducing the nutritional input tremendously. Very good, very good. Dr. Jamil, please.
Yes.
Floor is yours. I really want to talk about your case.
Okay, sir. So, sir, 20 years male presented to us after a history of road traffic accident with the fall from motorbike. When he was received in emergency, his neurological status was he was quadriplegic, and there was no motor sensory component below C5. So he was classified as a Asia grade A, and when we did his CTC spine, it showed C4-5 subluxation and significant translational injury.
Now, may I ask what kind of motor vehicle accident it was? Like a head-on collision, a from the back, from the T-boning, meaning from the side, and so on. Do we know? Do we have more information?
So unfortunately, we don't have exact information, but they only told us that he fell from motorbike.
Oh, he fell from a motorcycle. Got it. Okay.
Yes, sir.
Okay.
Yes, sir. So his CTC spine revealed C4-5 subluxation and a significant translation at that level. And when we got his MRI, it revealed subluxation and a significant cord contusion, which is extending up to C3 level. And there's disc disruption as well. And there's discoligamentous complexes also disrupted, yes.
So may I just stop on this picture, because that I think very crucial study. Dr. Aya, what do you think about this picture? Has Dr. Aya left us?
No, I'm still here. They need to scroll more in the axial, but there's obviously
but I mean,
it could be a facet dislocation because it looks like there's
that's a good take. We can't say if there's a jumped facet.
Yes.
We can't say if it's a jump facet, but with that much spondylolisthesis and with that much, what you see in the posterior interspinal processes, interspinal process ligament is extremely hyperintense. We might be dealing with the jumped facet. That's what I wanted to get at. And obviously you see that hyperintensity within the cord, which is not unusual. It goes up and down. But if the injury is in that level, what is the mechanism of the hyperintensity within the cord, almost 2 levels above and 2 level or 3 level below? 2 level above, 3 level below, we have that hyperintensity within the cord. What is the mechanism of that?
So it's due to the cord contusion and which results in the edema as well.
Well, the cord contusion usually is at the level of the injury, but the extension of it is venous
vascular. Yeah,
the venous backflow problem that causes edema. There is edema. Hyperintensity, it is an edema, but the mechanism of that edema is the venous backflow problem, because it's so narrow there, the veins cannot empty themselves. Then the pressure, the fluid of the venous structure get into the spinal cord. Either way, that is one of the reasons we need to act fast here, because Dr. Samadani has published numerous papers about that. There is a window there. If you pass that window, the level of the injury, unfortunately, the damage there and it's done. But that damage above and below can really extend if you don't act within certain period of time. So the significance of this picture is that possibly there is a jump facet, and then there is quite significant stenosis in the area of the index level, but 2 level above, 2 level below, there is significant edema. Those cells in the spinal cord there, the clock is ticking for them. Go ahead, Dr. Jamil, continue.
Sorry, one question. Did he get steroids? And Dr. Basi, what's your opinion on steroids?
Well, what do our society say? When I went to med school and residency, you would put patient on a medral on the solometral protocol, you would give them a bolus, you give them an infusion over 24 hours and so on and so forth. It was like, it would be malpractice not to do that. But now it's very different. What do our society say about that now, Dr.
So
Raya?
basically, the papers say that it shows no benefits. But if you are in a meeting with spine surgeons and you ask them who, if this happened to them or their family members, would want steroids, everybody raises their hand. So it seems to be very dependent on.
It is very schizophrenic right now. It's like a two word. In the societies, everybody says you shouldn't be doing that. But every surgeon I know, if you say present a young person like that and in a situation like that, they say, I absolutely would do that. And I would do that. But if you go to listen to our societies, everybody says based on this study, that study, don't give steroid. But I think this is one of those things that two academic places, they came out with two papers, and because they are prominent enough, they're pushing the agenda forward. Every surgeon I know that in a similar situation, young patient post-trauma, they would say, I would give steroid, and I myself would give a steroid on this patient.
Thank you.
Okay,
Thank you.
so Dr. Jamil, continue.
Yes, sir. So we planned ACDF for that patient, and he was operated within 24 hours of the injury. So while draping the patient, we saw neck fullness, most probably on the right area. So I thought that it might be some hematoma or something else, but I didn't had in my mind that it could be CSF. So
Okay,
while
may I ask what was the patient's motor and sensory level and exam? What was that at that point, just before the surgery?
it was Asia A. There was no motor sensory function.
So it was complete.
Yes, it was complete gone. Indeed.
Okay, it was complete at that level. Okay, that
Yes.
prognosis is obviously not very good for a complete.
Yes.
Yeah. Okay.
So while I was developing a plane between trachea and carotid sheath to land on the vertebral bodies, suddenly there was a gush of fluid which came out, and it looked like a CSF. So when that gush of fluid came out, the swelling subsided. So
now, in this case, it's very clear that the CSF and so on. I mean, what else it could be? But if in question, Dr. Rauf, what do you think if there is any question if the fluid is CSF or not? What lab test could be helpful?
It's beta, as I forget the name, beta transferrin test.
Okay, yes. It's very sensitive. It's only in the...
Or simply we can, if we have we can do a glucose test. So
yeah, but that's not
it's
that's
very
not as
fast.
sensitive.
In Pakistan, it's not available. So if we have a CSF leak from patient from trauma, so we do a gauze test, or maybe secondary we do a glucose test. So it will confirm us about
But beta transferrin is very, very sensitive.
Yeah,
Okay, very
sensitive.
good.
Yes.
Okay, Dr. Jamil, so you go ahead with your surgery. Go ahead.
Yes. Yes, sir. We did the surgery. I removed the disc and prepared the end plates with curate and drill, and then for the leak, I put in hemostatic material which we call sponge stone, and that temporarily sealed the leak.
Okay.
So yes, sir. So there was no leak at that time. So
could you identify the source of the leak at that point or not? So in a situation like that, everything is inflamed. Things are not that easy. This is a difficult case.
Yes, sir. So it was not the source. The source was not clearly visible.
Okay.
So I just used a hemostatic material, and when I removed the complete disc, I opened the posterior longitudinal ligament, and I saw the cord, and then I just put in the hemostatic material soaked with blood, so that acted as a temporary seal, and there was no leak. So I put in a cage and completed my fixation, and the translation injury was also restored. So just to be on safe side, I put in a drain. On first postoperative day, there was minimal output in the drain, and there was zero sanguinous. But on second postoperative day, output was 250 ml, and it's his third postoperative day now, and it's total 500 ml, which is in the drain.
Okay,
So
so let's go through certain things. Number one, some of our colleagues will say, go identify the source of the leak and close it primarily and so on. And unfortunately, I think you going there trying to do a big corpectomy, identify the source of the leak, you're just proving what a good surgeon you are. You're not doing patient a favor.
yeah,
Just
yes, sir.
tamponade it as best that you can. Do you guys have access to Durasil or Tesil in Pakistan?
Yes, sir. We have we use flow seal or fibrin glue for the
Yeah, flow seal is different. You know, flow seal is not really a sealant for the CSF leak, but Tesil, which is a fibrin glue, and
it's a
Durasil,
fibrin glue.
which
We
is the
mostly
blue
use fibrin.
thing.
Yes, sir.
The
Use
flow
fibrin.
seal is just that particulate gel foam with thrombin to stop the bleeding
Yes,
of the venous kind of bleeding, like at 4 centimeter water column. CSF pressure is usually between 8 and 12, and in somebody like that, maybe even higher. Flow seal is by itself never enough. Test seal is it is a good thing to seal the pressure up to 10, 12, and Durasil, the blue material, I'm not sure if you guys have access to that. That can seal it up to 25 centimeter column. What that means is that it's very good, but there's a problem with Durasil versus Tesil. And Dr. Aya, have you used either of them, Durasil and Tesil?
We use fibrin glue.
Well, fibrin glue, that's Tesil. Fibrin glue is Tesil.
Yes, sir.
And that is again good up to 12 and centimeter column. And the good thing about Tesil is it actually turned into live tissue. The problem with the Durasil, it is literally a monomer become a polymer, and your body breaks it down, and your kidneys are going to extrude that. It doesn't turn to the actual material, doesn't turn into actual tissue. But you're hoping by that time the leak has sealed itself. But test seal, actually, whatever you put in, it turns into actual material. Your cells go in and turn it into material. So it's more durable. But Durasil, the blue material, it can hold higher pressure. But by the way, as well can cause some pressure. So there is a give and take either way. But as we take to us, Dr. Jamil, in a situation like that, I would divert the CSF leak. I would put a lumbar drain. You remember, you put Tesil in. You want to reduce the pressure generally around 8 centimeter column so that pressure doesn't separate the Tesil from where you put it in. So at the lumbar drain, hard to deal with, but that I would say it could be very helpful to keep the pressure reduced in the CSF space so that area has a better chance of healing. But please go ahead, I'm listening. What happened?
Yes, sir. Now we are planning to put in a lumbar drain, and and then we will remove the drain and the wound, and we'll put in a lumbar drain, and then follow the patient.
Okay, so Dr. Jamil, you are a neurosurgeon, and so is Dr. Rauf, and Dr. Aya is an orthopedic surgeon. They don't deal with the dural, the lumbar drains. You want to give us a little bit of understanding about the concept and the parameter and the tenet of lumbar drain. How is it used? How is it drained? And so on and so forth. Do you want to give us a little information about how that's managed? Because putting a lumbar drain is easy. Managing it is really, really hard. Okay,
Yes,
so do you want to give us some information?
Yes, sir. So first of all, it should be placed in a aseptic and completely sterile environment. After that, we should keep a record of the output of the drain. We should track the output of the drain, and we should make sure that there is no leakage from around the drain side. and
Mhm.
it is probably draining into the burette, which is attached with that drain, and and we need to observe for the headache or any postural headaches or any sort of vomiting which causes postural headaches or hypotension. So we need also need to give fluids to the patient so that the patient doesn't suffer from any kind of headache. And it should always at away from all other body tubes. Lumbar drain should be on one side of the patient and all other body tubes on the other side of
Yes,
the.
yes,
Yeah.
good management. That's you don't so you never ever confuse them with other things. So number one, patient need to be flat.
Yes, sir.
Number two, you measure the foramen Monroe as your level. There is actually something that we put it at patients, and to understand where the foramen Monroe is, you can more or less aim for the base of the nose and the ear, or there's even an apparatus that you put the top and the bottom of the patient and their head, and you bring it together. It is
Yeah.
about the 40% from top to down. You choose that as your zero, and then there are two ways to deal with that. A lazy way, where the nurses go over 10 minutes, they drain 10 to 15 cc.
Yes, sir.
And I'm saying lazy way because then you just do that and then you document you did it and then you are done. But that's not the best way because you are not really sure uh, how long are you draining. Are you draining too fast? If you drain too fast, yes, you have hypotension, headache, but that's the least of your problem. You may have
Yes.
intraventricular hemorrhage, and
Yes.
have patient died on us during my residency because of intraventricular hemorrhage. Now, but the better way is you identify foramen Monroe, you keep the patient flat, and you bring that level of the drainage to 4 centimeter, meaning that your aim is to reduce the CSF pressure somewhere between 4 and 6, maximum 8. Okay,
Yes,
and you don't want to really go much above 8, but somewhere between, depending on how bad your leak is. I think 6 to 8 is a good number, but then you have to pay attention to the patient. You have
yes,
to make sure patient hasn't moved. You have to make sure nobody has kicked that thing. So it is hard to really
yes,
deal with that. That's why I call the other method lazy, because
yes,
here you have a nurse that have to pay attention to the patient all the time. But that's the
yes,
best. You keep that pressure in the cerebral area in the CSF space below 8, and your TESIL works beautifully if you can keep the pressure below it. I just saw Dr. Thomas joined us. Tony, are you there?
Hi, doctor. How are you? Hi, prof.
Good, good. Well, we are talking about the management of the lumbar drain for CSF leak in the spine, but we deal with that with our sphenoid meningioma, we deal with that with our transsphenoidal and so on and so forth. And I was talking about the ways of managing the lumbar drain, that putting them is easy, managing them is hard. What is your favorite way of managing your lumbar drains?
Now, if I'm not able to close the wound properly,
Mhm,
then I will put a lumbar drain for the
mhm.
spine.
But when you
But
put a lumbar drain,
if I'm
how do
getting
you
a good
manage it?
closure,
Yeah.
if
How
I
do you manage it? How do you manage the lumbar drain?
lumbar drain, um, I put it like about 10 centimeters, and then I let it drain. And the important is to have a good nurse
Yeah,
to
yeah.
make sure that the lumbar drain is. If I don't have a good nurse, then I'll intermittently open and close.
Mm-hmm.
Then I start them on Diamox as well,
Yes, yes.
and
That
that's
is
a new
another
thing
thing.
we started.
Diamox or urea? Have you tried
Yeah,
urea?
urea.
Yeah, it's very cheap. It's very cheap, but it does. It literally it takes a lot of fluid out of the CSF space and divert it to your kidneys. Literally,
Uh, I haven't used it. No,
it is
mannitol,
actually
Lasix,
very
and
effective.
yeah,
That Diamox as well, it's
yeah.
the old medication works best to reduce the CSF production.
Yeah.
as well works. And I would keep it at 10 centimeter for my transcranial, for my sphenoidal, transphenoidal pituitaries. If I had a
Yeah.
CS leak, I would use 10. But as you know, in the spine, the water column is if you put it at 10
Yeah.
for the spine, the pressure is actually going to be 12 or 14 because
Okay.
you see, it's really your head and so on is higher than most of the spinal cord and so on. So for the it's very good. 10 is a good number, but for the here in this case, cervical CSF leak, I would probably keep it somewhere between 6 and 8. But then again,
Yeah.
as you said, you have to have a very good nurse paying attention to the patient all the time. Very good.
No, we can lower it depending on the if there
Output.
is some collection happening, I lower it,
Yeah.
and then after a few days, slowly raise it.
Yeah.
And
And
luckily, the drains we can keep it longer now
Yeah.
for 21 days. Yeah.
Dr. Jamil, if I was you, I would keep the drain in the neck and then put the lumbar drain and see. I would just raise and lower it until the neck drain has zero output and
Okay.
the lumbar drain has most of it. But you don't want to keep that neck drain too long either because that's a risk of infection that you don't want to really deal with at this point.
Yes, sir.
Okay. Well, thank you guys. That was very, very helpful. Tony, this case, I'm not sure if you were paying attention. Motorcycle accident, complete, I think quadriplegic at this time, or at least the significant the sensory and motor deficit, which is complete. Would you go only anterior or would you go at 360? And in the MRI, we saw there is significant hyperintensity in the interspinal process ligament. We think it might have been a jump facet. We are not sure, but
I think it's distracted quite a bit,
yeah,
but it's fine since he's quadriplegic.
yeah,
And I
yes.
would only go anterior if the patient is quadriplegic.
Okay. So yeah, it makes sense. If the patient is complete, you can just go anterior. But what other criteria do you have? Going only anterior, only posterior, or front and back? What would be your criteria?
No, I offer the patients 360 if they are intact,
Yeah.
because and I offer them a delayed, like 4 to 6 weeks. Sorry, my kids are all here.
No,
having Easter.
that's important. Take care of them. Now, depending on how fast you want to ambulate them, that is for me the criteria if I do front and back. If it's a young person and I want to ambulate them as fast as possible, I would do 360. If it's in your case, as you said, patient is paraplegic, there is not much a chance of ambulation, early ambulation. I think anterior or posterior is alone is as well a good option. But I would keep them in a significant brace and even maybe halo for a significant amount of time. Nobody uses halo anymore. We used to use them a lot when I was in the residency. Do you guys still use halos?
In Pakistan, sir?
No, I don't.
In
Okay.
Pakistan, it's not available readily, so it's expensive and usually it's used for C2 fracture or C3 most but in Pakistan it's not available easily, so we have to import it from the.
Okay, very well. Okay, well, Dr. Jamil, any additional information you want to share with us?
Yes, sir. Additional information that I noted flickering of his flickering movement of his lower limb today. So that so that was a very good sign for me.
That's very encouraging.
Yes, and the attendants were very happy. That made my day.
Yeah,
that sitting inside him, and that made my day.
Yeah, at this point, what can get him is actually a pulmonary situation or wound infection. So if you make sure he doesn't become septic and doesn't have a pulmonary, infection and so on. How many days ago was the injury?
So it was 3 days ago.
So if you see flicking, even like a 1 of 5, in lower
Yes.
extremity. That is a very encouraging. Flicking with intention or random flicking?
No, sir, it was not, it wasn't random. I told him to try to move his leg. That's when he showed some flicking movements.
Oh wow, that is very encouraging. That is that I think if just 3 days after complete, you have even grade 1, 1 of 5 motor activity in the lower extremity. Early ambulation, early rehabilitation is really the key.
Yes, sir.
Okay, so that just you have to, on this kind of patient, you have to put everything you got
Yes.
early on to increase their prognosis. Very good.
Yes.
Thank you for sharing the case with us. Please
Thank
keep
you very
me
much,
up to
sir.
date. I really want to know more about this young man.
Yes, sir. Sure, I'll keep you updated.
Okay, well, it is 11 o'clock. I know Dr. Rauf has a case. Dr. Rauf, I think you have a case. Is that correct?
Yeah.
So we can give you maybe 5 to 10 minutes as well. Quickly discuss your case if you like, or we can discuss it next month if whatever you prefer.
It's a long. We have a discussion, so it's good to discuss in next meeting.
Sounds
So
good. Then we
yeah,
discuss your case next week. Okay. I thank you,
okay.
everybody.
Thank you, sir.
Hello, sir.
Thank you for joining us, all of you. Thanks. Okay,
Thank you.
Thank you.
Mitch, can you stay on for a second?